We're taking this, 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 we're taking with a pinch of salt.
Dear ladies and gentlemen, welcome to another episode of A Pinch of Salt. Thank you for tuning in. Obesity has to be one of the hottest, if not the hottest topic in medicine right now. Finally recognized as a disease, not as a shameful result of a lazy and undisciplined lifestyle. It's as much a disease as diabetes or any other chronic non-communicable disease shaped by lifestyle, certainly, but also by genetics and ultimately by the environment we live in. Harmful to the heart, harmful to the kidney, large bearing joints and other organs, but also not always entirely undesirable, as we're well aware that patients on dialysis with a slightly higher body mass can be better off than patients with what we would consider loosely as a normal body mass. Treatment up to this point, very difficult. Lifestyle interventions, not incredibly successful. Bariatric surgery with a lot of auxiliary problems and issues. And now we're entering the era of successful pharmacological weight loss. So who to treat, how to follow up are just some of the many open and difficult questions in this field. And here to talk about all of this with us today is Dr. Allon Friedman. Dr. Friedman is a professor of medicine at Indiana University School of Medicine and medical director of an affiliated hemodialysis unit. He is one of the most renowned experts in the field of obesity and an author of many papers on this topic, with a focus on CKD patients, of course, as befitting a nephrologist. So, Allon, thank you for doing this, and welcome to A Pinch of Salt.
Thank you so much for inviting me. It's a real honor. And by the way, I love the title of your podcast, A Pinch of Salt. It's humorous and clever.
Thank you. Well, we were trying to get to, past sometimes the clutter of the discussion into something that is useful and which could be taken with a pinch of salt. So, in that vein, we're going straight to a case that all of us have seen or will see or are seeing on a weekly basis. And the case is very simple. You're treating, well, not very simple actually, but you're treating a patient with obesity stage 2. That would be a body mass index of 35 to 40, so pretty bad, and CKD stage 4. And the question is, how would you treat obesity? Would it be multimodal therapy? Would it be a period of formula diet? Would it be pharmacological therapy, surgical therapy? What would you decide, and how would you base that decision on? What would you base that decision on?
Sure. Well, let me say from the output that everything I say here may be very different than what would be considered appropriate 5 or 10 years from now. This is a rapidly evolving field. An enormous amount of research is being done on this topic, not simply related to obesity and kidney disease, but obesity in many other aspects, management, risks, and so on. So I'll do the best I can to try to answer these questions based on sort of current evidence and my own clinical judgment. So you've raised a theoretical patient here, stage 2 obesity and advanced CKD. How do you treat a patient like this? I think the first question, let me step back. There are several factors that you have to consider. First of all, what is your goal of weight loss? Has the patient tried weight loss before and failed? If not, has the patient had some success? What are the patient's feelings about losing weight? What are the treatment options available for the patient? Because, as you may know, not all treatment options are available to patients everywhere around the world, the same treatment options, and so on. So I would first get a sense from the patient what the obesity associated risk factors are. So the patient has kidney disease. Not all kidney disease is linked to obesity, but many of them are. Diabetes, hypertension, there may be glomerulonephritides that are. Polycystic kidney disease may not necessarily be linked etiologically, but as a risk factor for more rapid progression, obesity is such a risk factor for some of these disease processes. Does the patient have additional risk factors? Heart failure with preserved ejection fraction, for example, liver disease, fatty liver disease, sleep apnea, and so on, that may also affect kidney function. So it is a complex question, but we have to think about this in all of our patients. And for the most part, I think we probably can get a generally quick sense of what the risks are. Normally, if we feel that it's appropriate to lose weight and the patient is willing and interested in losing weight, because obviously that's the essential factor here. If they're not interested in losing weight, then you might as well forget about it. Move on to something else and save your time and energy. But if they're interested, then we think about the options. There are three main pillars of obesity management: lifestyle intervention, which actually encompasses a lot of things, not just diet, but exercise and other behavioral issues, sleep, and so on. Pharmacotherapy, which, as you alluded to, is this just revolutionizing medicine these days with some of the new medications, and then bariatric metabolic surgery. So I normally consider to be lifestyle intervention first-line therapy, regardless of what comes next. And I think we also have to think, before I touch upon lifestyle intervention, we have to understand that just like we treat, for example, hypertension with lifestyle interventions, low salt, stop smoking, reduce alcohol intake, and increase exercise, and so on, as well as using, if needed, multiple classes of medications. I think we have to think the same thing about obesity. It's a chronic process, and it may need multiple modalities. So you shouldn't just think of you treat this or that or that. Sometimes we'll need to use them concomitantly. So we start with lifestyle intervention, and I don't usually first I get a sense of what their dietary intake is very briefly, because we are dealing with many other things. It's not so easy and maybe we may touch upon this. It's not so easy for nephrologists. We have time limitations. Our patients are complex and ill. We can't spend a half an hour talking about diet, but we can do a brief survey. Where do you normally eat? Do you eat out at restaurants a lot? Fast food? Do you make your own foods? Do you eat, do you drink sodas? This type of thing. What type of exercise do you do? Physical activity do you do? And so on. So I usually leave it up to them in terms of what type of dietary intervention, if any, they would be acceptable to them. I also use very frequently dietitians because they have much more time. They can talk about the issues. And once I have a sense of maybe perhaps some interventions that can be done from the lifestyle standpoint, in conjunction with dietitians and maybe even obesity medicine experts, though it's not so easy to get, at least for me, patients in a timely fashion because there's so much in demand. But once we deal with lifestyle interventions and perhaps some changes that patients can make, then we need to consider the other two pillars. In a patient with stage 2 obesity and advanced kidney disease, which I believe is linked to the obesity, I would probably begin with pharmacotherapy. And the reason why I say that is because it's much quicker to institute generally than bariatric surgery, which, at least for us, requires sort of a prolonged evaluation process, then several months where the patient needs to try to lose a little bit of weight on his or her own to satisfy the insurance company's requirements. So we're talking about at least 6 or 7 months. By that time, hopefully we can get the patient on one of the two most effective medications, which would be semaglutide or tirzepatide, and begin to lose weight. You never know how much weight the patient will lose. It's really very individual. It's possible that they may lose only very little weight or may not tolerate the medication. It's also possible that they may lose a huge amount of weight, and we may not even need to consider the third option, which would be bariatric surgery. So that's probably the general strategy I would use for this type of patient.
Yeah, that's great. I mean, thank you for sharing the clinical insight, telling us how you deal with these issues on a basic level. I always thought that I like the fact that you said non-pharmacological first, or at least concomitantly, because I feel like there's a lot of nihilistic attitudes about changing lifestyles. When I got into medicine, it was like nobody is going to change their lifestyle at all. And then I started working with kidney stone patients, and I found out that they're quite motivated to change some things as long as it helps them. And we have a nutrition clinic here in Ljubljana, and just reviewed recently the results of weight loss, and over a third of them lost more than 5% of their weight, which is an initial goal. You know, it shows that you'll have probably some positive outcomes if you lose 5%, which, like you said, the goal is important. You probably won't get back to, 120 pounds or whatever you had when you were 20, maybe. And, that may sound bad, but it's actually, if you look at the number needed to treat, that's three, right? You treat three patients and one got the result. So I'm happy that you mentioned that, but also for the pharmacological therapy, do you think that we should explain to the patients, which I think is the case, that this will be lifelong pharmacological treatment? Because that's how it looks like. And if you have to pay for it, that's an important piece of information, I guess. What do you think?
Absolutely. Let me just step back for 1 second and briefly address the issue of the efficacy of lifestyle intervention, because the data are not that positive. And what I mean is, first of all, there are many reasons to alter an unhealthy lifestyle, not simply kidney disease. There are many other outcomes that we can think about, and even the patient's feeling of overall well-being is another reason to do that. But when we look at, for example, I'll give you an example. There was a trial called the Look Ahead trial, which is probably the lifestyle intervention trial par excellence.
Mm,
It was funded by the National Institutes of Health, probably cost hundreds of millions of dollars. It randomized over 5,000 people with type 2 diabetes and obesity to an intensive lifestyle intervention or just standard education. By the first year, the people in the intensive lifestyle intervention arm lost more than 8% of their weight, which is very impressive. But over the next 7 years, they basically began to regain their weight. And at the end of the trial, there was only a 2.6% weight loss difference between them and the standard education arm. And that is with probably as much support as you can imagine, with the full NIH's strength behind it. And the point that I'm trying to make is not that lifestyle intervention is not a good thing or important. It's just that for most patients, it probably is not that effective in leading to sustained large weight loss over time. So that's why, fortunately, we have these other options. Because for most people, it's, as we know, in our personal lives, friends, family, even perhaps ourselves, it's not easy. It's very hard, actually, to lose weight and keep it off over the long term. So I just wanted to mention that in terms of, the efficacy of lifestyle intervention. And of course, as I mentioned previously, it's very, very important for the patient to be part of this. As you said, if they're involved and interested, then it makes it infinitely easier. If they're not interested, you might as well move on to the next task.
sure. So
And you mentioned, I'm sorry to
go
address
ahead.
your
Sure, sure. Go
question,
ahead.
about letting the patient know that this is going to be an indefinite treatment, at least at this point. That is absolutely an important thing to tell them. What we know is that if, first of all, that the effects of these very effective drugs do wear off fairly quickly. And there was just a study of tirzepatide, which found that very soon after tirzepatide was stopped, you began to see a regain of weight and a reduction in some of the benefits of the metabolic and intermediate cardiovascular and kidney risk factors, like the glycemic control, blood pressure, and so on. Things started to worsen again after almost immediately after you stop the drug. Now, there is a new drug, I understand, in the pipeline, which may have a much longer half-life, so maybe you won't need to take it as frequently. But still, at this point, as you said, we believe that this is going to be, if you want to maintain the benefits, this will need to be an indefinite treatment. And that's something that has to be discussed with the patient.
Sure, sure. So moving on to a next tricky topic in weight loss is, can we safely lose weight and usually you want to lose fat mass, right? Without losing too much muscle. You will lose some muscle, which is, it makes sense. If you have a huge body to move around the world, you'll need more muscles, but we don't want to lose too much muscle for sure, because, as medical students, we were used to thinking of the heart as the organ that will lead to a long life, and kidneys and whatnot. But really, it's probably the muscles that mostly define how long we live, because as long as we can move, we're going to live. And when we can't, we all know what happens then. So can we lose weight without losing too much muscle? And are there, differences between the methods in the sense of how much muscle you do lose? Because especially in patients like diabetic patients who often have initially sarcopenic obesity, so already not enough muscle mass. So what's your view on that? Is that possible?
Yes, your point is very well taken. And this is again an area of active interest. There's been some concern about these weight loss drugs and their effects on reduction in muscle mass. The fact is that the only data we have on this particular issue are from secondary analysis of trials with other primary endpoints. So as far as I know, there has been no dedicated trial looking at change in body composition, muscle mass, and quality of muscle on GLP-1 receptor agonists. But I think to get to the heart of the question, it really depends upon how much muscle loss is too much, because these drugs have shown, benefits in improving cardiovascular endpoints, including mortality, kidney endpoints, and even total mortality. So, um, and there doesn't seem to be in these secondary analyses um, concerning signals of reductions in functionality. So, for example, the 6 minute walk test, um, and so on, and other ways of measuring functionality or frailty. So that's, I think, should make us feel a little more comfortable. In addition, at least theoretically, there are some reasons to believe that the GLP-1 receptor agonists may upregulate pathways that lead to muscle anabolism and downregulate pathways that lead to catabolism. Again, this is yet to be confirmed definitively in prospective trials, but that's I think something that should make us feel a little more comfortable. And so overall, I think we need to, before we make any decisions based on muscle mass, I think we need to uh, wait for more definitive evidence to be published. But at this time, as far as I know, there's not been any, for example, concerning signals from the clinical trials that there's an increase of falls or frailty or other adverse outcomes. In fact, they don't see that at all. So I myself am comforted by these things, and I have not seen any patients of mine on GLP-1 receptor agonists that have had issues with weakness or other problems that may lead to reduced functionality.
Yeah. That's been my experience as well, but I have to say that's part of the reason why I think non-pharmacological approaches are important when you do give pharmacological therapy as well, because all of our patients get information about physical activity, and we check the hand grip and the sit to stand test, and it's not worse after they lost weight. So then you can
That's
be,
excellent.
yeah, then you could be comfortable, and they actually, it seems like they're doing it, at least, and their sit to stand test often gets way better, because when they lose weight, they become more mobile. So it's also very motivating for the patient. Now, you've mentioned that the non-pharmacological approaches are not very successful, at least in the long run. So it's highly likely that we'll be using a lot of semaglutide, tirzepatide, as we do use antihypertensive and hypertension, because just the non-pharmacological therapy approaches are usually not enough. But we're all, as doctors, I think we're kind of conservative. We're always a bit scared of new therapy. At least that's my experience. And even though semaglutide has been used for 20 years without any major issues, when would you be cautious or apprehensive about giving pharmacological therapy? When would you think, oh, maybe not?
That's a great question. I putting aside the contraindications, so medullary thyroid cancer, familial endocrine neoplasia, and so on. If I think there really are not many circumstances that I can think of. Perhaps if you have a patient who's so apt to acute kidney injury due to volume depletion for whatever reason, because these patients will have reductions in dietary intake and very often as well in fluid intake. So, and I've seen this before that you have really striking episodes of acute kidney injury, and they don't occur very often. But when it happens, perhaps there's some individual predisposition towards that. Other than, and even that patient, I wouldn't necessarily not try the drug. I would just be extra cautious and careful and perhaps monitor them a little more closely. But I can't think of really any obvious contraindications uh, other than the ones that are on the label. But I think for the most part, generally, unless again, perhaps a patient who has diabetic gastroparesis that is just terrible, this is bound to potentially worsen it because it does slow gastric outlet uh, flow. I think that for the most part, most patients are eligible for these drugs. I don't know what your experience is. I'm interested to hear what your thoughts about this question.
No, I have a similar attitude. I'm sometimes I question what to do with patients who have gallstones or might have had pancreatitis. I've recently had a patient who had a biliary pancreatitis while on semaglutide. Were these two things connected? Should he continue? Should he not? It's I guess if you know that you'll be able to follow up the patient very well, then that's a different story. And that's the luxury we had with dialysis patients, because we get a lot of dialysis patients who want to go on transplant and the surgeon wants them to lose weight. So
Yes.
that's when you see them 3 times a week, then you know that you'll change something if it really doesn't go well. But otherwise, I
Yes.
completely agree with you. Yeah.
Yeah. Andre, I will say that I did see once a patient in consultation, for a single visit, who came to me who was on, I believe, semaglutide, and had a history of pancreatitis and was coming in out with nausea and vomiting and abdominal pain, and I was concerned about it. I believe I measured a lipase, and she seemed to have mild pancreatitis. I stopped it immediately in that patient. But when you look at the literature, it's not clear. If not clear if there's a causal relationship between these drugs and pancreatitis. Perhaps it was a
Mhm.
coincidence or not. It's hard to say, but I didn't want to take the chance in that particular patient.
True, yeah. Um, so let's look at another perspective. So generally, we all agree that diabetes and obesity. Well, we're talking about obesity now. So obesity generally is not good for the kidney, and that losing weight will generally probably be good for the kidney. But then, because of the issues of sarcopenia, we sometimes discuss whether these people should have a little bit enhanced protein intake while they're losing weight. And then enhanced protein intake could be harmful to the kidney if you're a pre-dialysis patient. So there's some discussion about that. Are there any long-term data from these trials that, yes, losing weight with GLP-1s is beneficial for the kidney in the long run, or with tirzepatide, or with non-pharmacological weight loss?
Sure. Well, first, let me address the issue of the protein restriction, because even that is a little bit controversial. I mean, when you look at the different societies, they will have different recommendations. So my philosophy, which is not necessarily grounded in any hard data because there are none, is that the key thing for my patients is for them to lose weight. I think for so many beneficial reasons. I'm much more comfortable with loosening any dietary protein restrictions in these patients during this period of time. But I will say that, look, if they're going to be on one of these GLP-1 receptor agonists, their their appetite is really suppressed. So loosening up restrictions may not actually change their dietary intake much. They're just not eating
Yeah.
that much. So it's not that they're going to go from 0.6 grams per kilogram of protein to 2 grams per kilogram. Maybe they'll go to 0.8 or 1. Does this have any adverse effect? I am not, I would tend to believe that probably not. Um, but I'm sorry, you had another question there about the thrust of your question was whether or not there are long-term data. So there is one long-term study, and that is the FLOW trial, which is really now, this was published last year in the New England Journal of Medicine. It's, in my opinion, one of the seminal trials in nephrology, and it randomized patients with type 2 diabetes and obesity to semaglutide, actually a fairly low dose, 1 milligram. The highest dose is 2.4 milligrams a week. And they followed these patients over a median of around 3.4 years. And they found dramatic benefits. They found a 24% reduction in the total kidney composite endpoint. And if you break up the composite, there was a clinically and statistically significant reduction in cardiovascular deaths, in reduction of EGFR of greater than 50%, and even a trend towards significance in EGFR of less than 15. And then there were secondary endpoints that were also positive. Cardiovascular events, total mortality dropped statistically and significantly by 20%. So the FLOW trial, that is one trial. I would like to see it, and it will be, I'm fairly certain, it will be followed up by other large clinical trials with kidney endpoints. But the FLOW trial, I think, demonstrated that these drugs are effective and safe in our population up to 3 or more years.
Sure. I can't remember for the life of me at the moment what the weight loss was in the FLOW trial. I'll have to look that up, I guess. Do you know perhaps?
I would tell you the average weight loss, average weight loss difference between the groups was around 4 kilograms. So not really that much.
Yeah.
And actually, that brings up another interesting issue with these drugs is one would intuitively believe that so much, if not most, perhaps even all of the benefits of these drugs are related to weight loss. But when you look at the clinical trials and the data from the two prospective trials, FLOW and SMART, as well as several other trials that had kidney endpoints that were secondary endpoints or post hoc endpoints, you see very little of any relationship between change in weight and improvements in the kidney parameters. So we may find that and it wouldn't be surprising, we may find that the benefits of these drugs on the kidney are fairly weight independent, which raises a whole nother issue. Should we consider treating, many of our other patients who are not overweight or obese with these drugs?
Sure. Yeah. We'll see.
We'll see. We'll
Yeah.
see.
Okay, now for the penultimate question. So of course, obesity is not just too much fat mass, it's a whole lot more than that, and not just cardiac adverse outcomes or kidney adverse outcomes. These patients often have metabolic dysfunction associated steatotic liver disease, very often obstructive sleep apnea. These are all things that are detrimental to their health, especially obstructive sleep apnea, I would argue. And many of them are not aware of that. Are we as nephrologists, as doctors who are in the middle of taking care of obese patients, we see a lot of obese patients, should we be involved in this a little bit more? Should we be sending these patients to get their stop bang questionnaire done or whatever? Should we be involved more in the other aspects of obesity? Because the patient is one being with all these issues, not just the kidney issue. How do you deal with these other issues related to obesity?
I don't want to make a blanket statement, but I think it really depends upon the individual nephrologist. I suspect that most nephrologists are so busy that it would be a challenge to take over some of these other organ system dysfunctional organ systems because of obesity. But if you're going to treat obesity with these drugs or with surgery and lifestyle intervention, it's going to benefit some of these other organ systems as well. There are nephrologists I know who prescribe the GLP-1s themselves. There are other nephrologists who refer them out to the primary care doctor and say, I would like to start, can you please start this medication? It really, I think, depends upon the physician's time and how much they have of it to devote to these issues. Because just to reiterate again, as everyone here is probably listening probably knows very well, we have a lot to deal with in our patients.
Yeah.
And it's not, and though I think obesity is a central aspect of it, we can't spend, 20 minutes or half an hour of our time probably talking about this alone. There are many other things that we have to deal with. So I think the best strategy for most physicians would be to work in conjunction with other physicians, primary care doctors, obesity medicine specialists, hepatologist, if the liver is involved, respiratory physicians, a pulmonologist, if sleep apnea is involved. There are ways to do this, I think. The key thing is for nephrologists to be aware that obesity is a central risk factor for the development of progression of kidney disease and worsening of morbidity and even death in our patients. As long as nephrologists get that message, then I think they can use their colleagues to help deal with these other issues.
Yeah, yeah. We can't do everything ourselves for sure.
Can't do everything.
It's just particularly with sleep apnea, it's the thing is just it's difficult to change your lifestyle when you're struggling to keep just awake through the day.
Yes. Yes.
Sometimes it's very difficult to change anything without changing this first. And if you're aware of that, that might help the patient at least to, point them into the direction of a respiratory specialist. Okay, that's great. Thank you. Let's just now move to the final question, which is not about obesity anymore. It's more about you. We like to learn something about our guests. And so we use this kind of silly but simple question, which is which book, 2 songs, and luxury item would you take to a desert island?
This is probably the hardest question. All the
Everybody
questions
says that.
that you've asked me.
Everybody says
This
that.
is a challenging one. Well, I think, okay, the book, probably the Bible. 2 songs. This is a tough one. I would probably say I'm going to mix and match here. Hey Jude, the Beatles song, as well as the Trout Quintet from Schubert, which is sort of very upbeat. And if I'm going to be on an island by myself, I need something to fight off the depression.
Okay, which quartet is that from Schubert? I lost.
It's the Trout Quintet.
Oh,
The
the
Trout
Trout.
is called.
Yeah, the
Yeah,
Trout. Yeah,
it's a very upbeat and beautiful piece, which I
it
enjoy
is, yeah.
listening to very much. Yeah, and in terms of a luxury item, so I settled on, if I'm going to be on a desert island with all these privations and difficulties, I want to at least sleep well. I want a luxury mattress. That's what
Sure.
I'm going to ask for. It was
We
either
get,
that or a luxury kitchen.
yeah, yeah,
One
yeah.
of the.
We get a lot of these answers. We had the Bible before as the book, and also a mattress, a pillow, or a coffee machine.
Okay.
These are very common ones. Yeah.
Pillow's a good one too.
Yeah, yeah. And Hey Jude is an interesting song. Apparently, it was written for Julian Lennon, I believe.
That's right.
And I just listened to an interview with him, and he looks so much like John. It's crazy. And then he said that everybody says, "Oh, your father was a great man," and then he says, "Well, not to me," which was
Oh, okay. Well, this song, I think, when it was first came out, was, I think, the longest pop song ever recorded. It was over 7 minutes long
yeah, is
at
that
that
true?
time.
Yeah, yeah.
Yeah.
And then Freddie Mercury apparently said, "Well, let's see that. Let me top that with Bohemian
Oh,
Rhapsody."
really? Okay. That's funny.
Perhaps.
I like that.
Yeah, yeah.
I like that.
That's great. Well, thank you very much for sharing all of this. An evolving field. We need to be part of it for sure, any way that we can. And I think that you've given us some very useful clinical information with a pinch of salt, and we thank you for that. And have a great day, Alan.
Andre, it was a pleasure and an honor to be on your podcast, and I hope that we have the opportunity to meet in person sometime soon.
Me too. Thank you very much.
Okay. Take care. Bye-bye.